Hi, everyone, and thank you for attending the Texas Epidemic Public Health Institute and P2R Consortium's Infection Prevention and Control webinar series. Today's lecture is called the Infection Prevention 310 lecture, and it is titled IPC in Special Populations. This lecture will provide a brief introduction to infection prevention and control practices in special populations within healthcare settings. Today's lecture is recorded, and you will receive a link to the recording within a week or two from the presentation, along with the slide deck. So again, today's lecture is recorded, and within a week to 2 weeks, you will receive a link with the recording of today's lecture along with the slide deck. If you're new here or returning, we welcome you. The format of today's lecture is that we'll go into the lecture and then we'll go into a knowledge activity, which I encourage everyone to scan the QR code and participate. And then we'll go into some question and answers. So I ask for everyone to keep their questions until the end and be willing to participate in the knowledge check activity. My name is Dr. Kayla Rush. I am a seasoned infection preventionist. I have experience in acute care, long-term care, and skilled nursing home facilities in Texas, New York, and California. I'm a certified infection preventionist and a public health professional, along with healthcare accreditation. And I also hold my PhD in epidemiology, which my research focuses on training and education, along with orientation practices for infection prevention and control professionals. And I work here at TEPI, or the Texas Epidemic Public Health Institute, which is housed at UT Health Houston School of Public Health. And the goal of TEPI is to keep Texans safe and the economy strong by strengthening the capacity and resilience of the Texas communities to respond to future or upcoming infectious disease outbreaks. Today's lecture has been approved for multiple continuing education hours, or CEs. To obtain your CEs, you will need to attend the lecture in full capacity, so 100% of the activity, complete the post survey and knowledge activity, and score at least an 80% on the knowledge activity in this. As I mentioned before, the lecture is recorded, and within a week or two, you will get a recording of today's lectures along with the slide deck. At the end of the presentation, there is a slide that shows you instructions of what you need to do to complete your continuing education hours. So make sure you pay attention to the end of the slide deck with a slide that tells you step by step of what you need to do to complete your continuing education to get your certificate. This lecture has been approved for multiple education hours, such as medical accreditations or CMEs, along with nursing continuing education hours, along with health education specialists, public health, and sanitarian continuing education hours. This lecture has also been approved for continuing education for individuals that hold a CIC or an APIC, which is a certification for an associate in infection control or a certified individual of infection control under CBIC or the Certification Board of Infection Control. One disclosure, I am a subject matter expert and consultant for BD or Becker Dickinson. However, this presentation will not showcase any products or relate to the company at all. This lecture does not endorse any products throughout it, and I will not be talking about any products. So today's learning objectives are to specifically define and discuss IPC in behavioral health populations, pediatric populations, and outpatient settings. So before we get into special populations within the infection control, I want to go over some general things that you will use to apply to any population that you work in. So it doesn't matter if you're in acute care, long-term care, or a skilled nursing facility, or if you work in special populations such that this lecture will talk about with behavioral health, pediatric, or outpatient. The first thing that you always want to focus out, no matter what population you are, is your facility annual risk assessment. And two major models that I use and encourage other infection prevention professionals to use is either your epidemiology triad model, which you'll see on the left-hand side, which is the relationship of the infectious agent, your susceptible host, and your environment. So this looks at what specific agents, such as if you're working with bacterial, viral, or prions, or fungi for our candida, our environment, which is our healthcare space. So looking at what specifically goes into your environment, your HVAC system, your cleaning, your rounds, just what activities and lines of care that you are doing within your environment, and then your susceptible host. So who is that with your patients or population of interest within your environment? The next model that you should also be paying attention to is the One Health model, which looks at the relationship of human health, so us humans and what we have colonized, our animal health, so what's going on in the environment with our animals, especially that we've seen more spread of zoonotic diseases such as H1N1, mad cow disease, bird flu. We're starting to see more spillover of these zoonotics, so knowing what's going on within our communities in the animal health is also very important, along with our wildlife and then our environment. So making sure that we know what's going on in the human environment in and out of facilities, so that we know if there are certain pathogens, fungal agents, or parasites that our populations might come into contact with, that we need to ask more epidemiology questions, such as if you are working in a space and a lot of your patients or population is based in agriculture work, asking about zoonotic infections, such as have you come into contact with dead or ill animals? Have you been working in the soil? And what specific pathogens and parasites and funguses can be spread by soil transmission, along with other pathogens of interest. And that information will go into your annual facility risk assessment. You will grade a certain risk based on the likelihood of occurrence and the consequences. So this is a great visual graphic that I like to use that really kind of puts the importance of different low versus high and what the outcomes are. So green is always what we strive to be in, of that insignificant or rare, unlikely event of something happening, compared to our red, which is most certainly likely to happen and catastrophic. And those high or extreme category issues that could lead to a patient death, a staff member death, or a citation from a regulatory body, and they're really unsafe, and we really want to work towards to reducing them. So this is a great way when you're looking at your annual risk assessment of what policies and procedure and what infection control risks are your environment based on your population of interest that you're looking at. You can use to kind of score your annual risk assessment. And that annual risk assessment looks like this. Your first, on your left-hand side, you'll have your program components, and then you'll score in the 3 different areas of probability of performance failure, so the likelihood that this is going to fail. And then is that a high probability that it's going to fail, so it most certainly will fail? Is it low, or is it never? You're really good on that specific metric, and it's likely for that to happen is never going to happen. Our impact, so if there is an impact, if something happens, is a high, moderate, or a minimal impact? So is that a high consequence, a moderate, or a minimal from a safety measure, operation measure? We want to look at that impact and include things such as your clinical, financial, and resources, along with staffing. If something happens, if there's an outbreak investigation that happens of a high consequence pathogen, the impact is going to be very high, and that will also be a high impact for clinical, financial resources, compared to if you're looking at a shortage of specific supplies. That could be a high or moderate impact, or something that could be very minimal impact. And then the infection prevention system that you have in place. So do you feel really strong that that area of IPC is performing well, or is it performing good, fair, or poorly? And then you want to overall give it a score and then set your annual goal. So when you're scoring this, 0 is the process is going well, so you're doing it 100%. There's no gaps, and there's no likelihood of failure. Low to 1, the process been initiatives and followed, but maybe you're not at 100%. Maybe you're at 95%. Medium to 2, the process in place are working well, but there's areas for improvement. And high or a 3 rating is that indicating that there's an issue, and that is something that you'll be educating. Maybe you're developing a new process improvement plan, doing a PDSA cycle on it, looking at different staffing, operational input through of how to reduce this specific harms. And these are just some examples that go into your infection control risk assessment. So looking at your total procedure HAIs specific for your patients. So are you having surgical site infections, central lines, urinary catheters? Is C. diff a concern for you? Failure of prevention activities, lack of screening, antibiotic, OR, environment. So what's going on in your environment and your equipment, along with your policies, procedures, along with your preparedness efforts. So making sure that you're ready for an outbreak, a specific terrorist event, or a weather event. Since I'm here in Houston, Texas, and we're just coming out of hurricane season, so making sure that we have generators, we have water, we have electricity backup in our healthcare areas, so that if something does happen, that those critical life-saving things that we need, such as electricity for our ventilated patients, that we have, along with our employee health. And then our antibiotic resistance organisms are always a concern. And this is just an example of one of how you would set it up, of those different components that I just showed, and then scoring them. So you want to add up your score. So going across the columns, such as for surgical site infections, we have a 2, 2, and 2, so that equals 6. And then you want to set an overall goal. So since there's been an uptick of surgical site infections, we scored it as a 6, but our goal is 5. So there's room for improvement. We're going to work in the next year to make certain initiatives, develop different committees for that. So you want to do those for all components. And just another consideration that before we go into talking about these special populations, of looking at what your HVAC has in your specific building, especially that we are talking about today a lot of outpatient areas or clinics. Those are not traditional healthcare settings. So that building or that clinic might have been acquired and not initially set up for healthcare. We see that very frequently, that we have a building or a retail space, and then they come in, a hospital or a health system acquires it and turns it into an outpatient clinic. That HVAC system is not set up for healthcare. So making sure you know what your HVAC system and what your electrical grid is within your building is really, really imperative, especially in these non-traditional acute care inpatient settings. So knowing what your air exchange, how that feeds into the building, especially if you are in a clinic that might be on like on one specific floor of a multi-floor building. So your clinic is on floor 6 of a 10-story building. If you have a patient that has a pathogen that is disseminated through airborne transmission, how is that air getting filtered on your clinic, and where is it going? Is it going into the next floor, or is it going out of the building? So making sure that you know that going up, it will really feed into your preparedness efforts and your outbreak response plans in any type of outpatient areas, and even within inpatient areas. This is always a consideration, no matter where you are working in healthcare, if it's inpatient, outpatient, if it's clinic, if it's acute, if it's a skilled nursing home. You always want to know what your HVAC considerations are, because that will dictate some of your policies and procedures. And if you need to put a HEPA filter, if you have anyone that becomes positive for COVID or TB or any type of airborne pathogen transmission, you will need to know what kind of the infrastructure in those areas. So that's just kind of some background information before we get into the special populations that will tie into all 3 areas. So I'm not going to repeat it, but you'll see some of those things pulling into each category. And so the first category I want to talk about is behavioral health populations. And these are kind of an overview of individuals that have mood, personality, psychosis, anxiety, or substance abuse, substance use disorders. These are very diverse settings. This could be an inpatient, this could be an outpatient, this could be a residential or a group home. And this is kind of the balance of mental health, other comorbidities, because not only do we have mental health challenges and treatments, but other things such as COPD and some chronic issues with our kidneys. On our heart and just other things that will need to be monitored, and then goes into infection prevention. So this is kind of the triad of these three things that we try to balance when we're working in behavioral health populations. And these are kind of just some overview things of looking at the main thing in this area. You want to look at risk of self-harm and infection spread through patient interactions, cleaning practices, especially with shared equipment, surveillance, reporting, and environmental and engineering controls. And kind of to dive more deep into your specific plan, you want to do foundations, which are the four main things. Look at your foundations, immunizations, your surveillance, and intake assessments are going to be the backbone things that go into your specific IPC plan and program development for this area. So the first one under the foundation is doing a facility specific risk. So do a gap analysis or a facility specific risk assessment. And you want to look at your environment of care. So looking at how your facility is set up, especially in behavioral health, are there specific safety issues such as ligature risk areas? So that could be a door handle, that could be a light switch, that could be other type of areas that you just don't really think about of it being a ligature risk, along with how does that affect the environment of patient and staff safety. Also with ligature risk, which is a huge safety concern in this area, that you want to make sure to be aware that PPE can also be a ligature risk. A mask or a gown could be a ligature risk. So knowing how you're going to handle masking and PPE storage, maintenance, and access for staff is really critical, along with having appropriate disinfection equipment, sanitizer that is available for staff, but locked away and kept away from patients too. So you want to have this balance of safety, but still giving our healthcare staff what they need in the infection prevention and control area to be safe. So our PPE, our hand hygiene, and our disinfection, but making sure that that's safely kept away from our patients in that area. What treatment modalities do you have in your area? Is that water aerobics? Is that group therapy? Is that going on walks? What specific area in your behavioral health? And then along with, is there different hierarchies of behavioral health patients that you take? Is it a specific group, or is it a wide range of behavioral health challenges that your patients will exhibit within your organization? So you'll need to be mindful. The next thing is immunization status. So this applies to patient and staff. So having clear documentation of everyone's immunization status to decrease transmission is huge, along with if are your behavioral health patients seeing just adults, or they pediatric populations as well. Because when we get into pediatric populations, based on their age, they might have had different vaccines. They might have not been vaccinated, depending on if they're eligible, what specifically you're seeing within your group, that you'll need to be mindful of. The next is surveillance, is looking at devices. As we said before on the previous slide, are other comorbidities. So if they have issues with their kidney function, are they on dialysis? So therefore that they have a central line and they will require dialysis. Are they incontinent? Are they history of any type of urinary retention or other urinary issues, so that they have a Foley? Do they have any feeding tubes? So any lines, drains, or airways that we want to be mindful that these also pose a risk depending on our mental health of the individuals, if they will be manipulating them. So that we'll have to do education with that patients, and then also have really good surveillance on those devices. And then it goes into equipment. So making sure that these are usual spaces that are not traditional hospitals. There's congregate living, there's a lot of shared equipment. So making sure that we know what equipment it was in our space, and then what requires high level disinfection and sterilization, and then where that needs to be stored. Along going into our HVAC considerations, that equipment has certain temperature, humidity, and pressure regulations to be in storage, such as our scopes being in a air pressurized cabinet for high level disinfection. So any of your endoscopes, if you have them, or if that's just on the inpatient side, or if you're not having any scopes in these areas, which are unlikely, but you never know. So making sure that we know what the regulations are if we have any pieces of equipment in this space that require certain temperature and humidity. And then lastly, our intake assessment. So a very detailed history of looking at community exposures, especially if these are unhoused populations, they are at risk of transmission and being exposed to other pathogens. Or if they come in from correctional areas or any environment that has high transmission, of knowing where they came from and what was going on in that facility. So in case they are asymptomatic and incubating that pathogen, you can put them in isolation. They can be identified of what cultures or assays that need to be ran on that patient before potentially putting them in group therapy, where there is close contact with other patients and increased risk of transitions, along with previous past infections, and then also risky behaviors, especially when you're screening STIs and STDs. These are notifiable conditions. Based on your state in Texas, making sure that we're reporting any type of MDROs, and the CDC has put out before that there is starting to see an increase of STIs, STDs, MDROs, such as MDRO, gonorrhea. So making sure that we are identifying these individuals and then making sure that we're reporting them and getting them treatment. In the Houston area, we've also seen an increased risk of syphilis within our community. So that's another STI of making sure that we are screening for in these patients. The next thing for an infection kind of risk factor is communal leveling. As I mentioned before, the behavioral health areas are non-traditional areas, and there's increased risk of patient transmission based on how the area is set up. As I've already highlighted, self-harm behaviors, making sure a ligature risk can also be complicated, especially with IPC equipment, as I mentioned before, as masks and gowns can be seen as a ligature risk along with our sharps that we use, and that could be potentially dangerous and used to self-harm a patient. So making sure that you are talking and getting feedback from your frontline staff is critical, along with occupational health issues such as transmission, safety and mental health, wellness of staff, and then outbreaks linked to delayed recognition reporting. I'll talk about all of these in detail. So the first number one thing that you can always do is hand hygiene. Hand hygiene is always important to make sure that you are promoting hand hygiene, you're talking about it, even in healthcare areas that we talk about, it's still not 100%. So the number one way to decrease transmission is always clean hands. So talking about it, making sure that you know when to perform it, and then you're encouraging your patients or residents to perform hand hygiene. And then this is just a graphic of the WHO's 5 moment of hand hygiene. So making sure that we are promoting this, along with other types of sanitary equipment within the behavioral health space. It might depend on your policy and procedure or your specific area of, if bar soap is prohibited or not allowed because of the potential choking risk that it could cause. Are razors and shaving cream allowed in your area? So making sure that you know what's in your policy and procedure of what's allowed, and then reinforcing and monitoring that surveillance for those sort of safety events based on that. Another thing in behavioral health areas is group participation risk factors. So there's a lot of focus on group therapy along with communal dining and grooming, which increase risk of transmission. So definitely being very strategic about when we should have group therapy, the spacing between members, if you can have it outside so you have more clean exchange compared to inside, as well as a way to reduce transmission. And then also working with EVS nursing and engineering to make sure that everything is cleaned. so that we are not having particulates stay in the environment longer, because this is very much more a communal living area. So there's more freedom and people are going in between and kind of sharing different things. So also a big emphasis is going to single-use patient items. That's always better than multi-use or repeated use to decrease transition risks. However, that can sometimes be a costly way and be a financial burden. And then hand hygiene, hand hygiene, hand hygiene. Another issue when doing environment of care is shared bathrooms and bedrooms. In behavioral health areas, sometimes there are multiple patients per room or unit. Depending on your facility, you could have 2 to 6 patients sharing a bathroom area. So there's increased risk of transmission. And due to the congregate living area of this, of then identifying isolation rooms. If you need to have a patient isolate because they have been exposed or they potentially could be incubating based on that intake form, what room are you going to put them away in until their quarantine time is done, along with designating a specific bathroom to this individual. Cleaning and disinfecting is a high issue of great concern, and making sure that you have strict schedules, especially with high touch communal surfaces, and adhering to cleaning schedules, to making sure that no piece of equipment is missed, along with linen, laundry, kitchen, and dining. Sometimes in these facilities, you have a kitchen area where individuals make their own food, or maybe not a full meal, but a small area where they can cook, along with doing independent linen and laundry services. So making sure these pieces of equipment have been processed by your biomed, and that there is a system in place where they are being checked either monthly, for sure, at least annually, but making sure that they are running appropriate temperature and duration to kill any certain pathogens that will either be on silverware or on the laundry themselves. And especially if an individual has to be isolated, say they have an MDRO, or they have a highly transmissible or respiratory infection or C. diff or any type of other pathogen of consequence, are you allowing that individual to do their linen and laundry in the communal area, or is there need to be another process in place where they do their laundry in another area? So talking about frontline staff of how to operationalize this space is really, really key. So you don't have transmission from patient to patient or resident to resident based on contaminated linen, any dining, such as, your silverware, your bowls, your soups, anything like that. Another concern is occupational health risk factors. In some of these areas, there's increased risk of violence and aggression to healthcare workers based on the behavioral health needs of the patients themselves, or if they're in a psychosis event, not having that mental awareness. So making sure that we identify and train our healthcare workers on de-escalation areas, along with these types of events of infection exposure, especially if individuals become in a state of disillusion and they become combative. And we've already kind of talked about environmental hazards and chemical exposures, making sure that there's a balance of safety of what we're using in this environment and our ligature and self-harm risks to that certain type of equipment. And then lastly, because of the unique challenges, there is work stress and burnout to these occupational health workers. So ways to control those is definitely having administrative controls, so specific training for de-escalation, post-exposure management, so making sure that we are reporting our bites, scratches, any type of blood exposures, and then you have that OSHA bloodborne pathogen exposure plan. If you're not sure what that is, there is a wonderful TEFI lecture call in the 200 series talking about the specific OSHA bloodborne pathogen exposure plan. I encourage you to look at that, of making sure that you know who your administrator is, what your assessment goes into for those exposures, and getting individuals prophylactic. Staff immunizations, the best way for prevention is immunization, along with our engineering controls of making sure that our room design, along with our HVAC system is set up appropriately to reduce risk, along with knowing when you can modify PPE based on safety. And and then promote mental health support and resilience for these healthcare workers. Another big thing, because it is a congregate living area, of looking at respiratory protection consideration, especially with highly transmissible things such as COVID and influenza. We are in respiratory season right now, so knowing when you should be masking individuals, or if masking, if you're deeming a ligature risk, how does that look like? If looking at isolation, maybe during certain season, if there's a high prevalence of respiratory infection within your group, maybe you pause group therapy and it's more individually, but these are some things operationally that you and your team, along with administration, will need to talk about, of how do you cohort, how do you track, and then how is it going to affect the health therapy that the individual is getting. And then lastly, going into surveillance, your surveillance, like anything, needs to be targeted, especially since there's communal areas of GI, respiratory, and skin. Making sure that we have those really good intake forms, so we're identifying high-risk individuals right away, so that we either need to culture them, put them in isolation, or send different assays right away, so we reduce the transmission spread within our facility. And then early outbreak detection is critical, so making sure that you have your surveillance data, that you know what's going on within your community. If you're seeing an uptake of certain pathogens, such as respiratory viruses within your specific area, that then maybe then you need to revisit certain masking policies, certain visitor policies of what can be seen safe in your organization, and then coordinating with local health departments when any type of outbreak happens, or if you think that there is an outbreak. As we presented last month, DSHS here in Houston or not in Houston, but in Texas, is a great advocate for collaboration, and they're really here to support us in our infection control needs. So in this area, we have unique infection risk challenges due to their communal living, and the balancing our mental health along with safety restrictions based on what these patients are experiencing. And as I mentioned, early outbreak detection, vaccination, surveillance is really, really critical. So next, we're going to go into our pediatric populations, and these are individuals from newborn to 18, and again, a very diverse setting based on our inpatient labor and delivery areas, our NICU, which is our neonatal intensive care unit, or a PICU, or pediatric intensive care unit, or for our non-sick babies, and it can be just a regular nursery. And then we have inpatient pediatric areas, hospitals, and units, and our outpatient clinics. Some considerations that you will need to always pay attention with this population is that depending on their age, they're very immune naive, especially when they're newborns. They have not had any vaccinations, and they've only had their immune system, that some of the antibodies that they have gotten from their mom, can be they're not only immune naive, but they can have immunodeficiencies and congenital disorders. So when looking at your specific risk in your area of going into your infection prevention and control plan and development for this patient population, you really need to look at your risk, likelihood, and impact. So making sure that we know what's likely to occur, the potential hard, and readiness. So main things that go into this infection prevention and control plan is patient risk, procedure and care, environmental and facility, family and visitors, community, and epidemiology risk. And I'll talk about all of those in each detail. So the first one with patient risk factors is, I've already mentioned, their immature immune system. So they're young, they're not fully developed. They can also be immune compromised. So these patients, even though that they're newborn, they can have cancer, they can require transplant, they can be HIV positive, or other types of congenital immune deficiencies. And based on how sick they are, they will likely have a high device utilization. So they will have multiple central lines, urinary catheters, or ventilators, and especially in the NICU or PICU, there's a high patient density. So based on how your facility is set up, you will most likely have multiple patients in a room, especially even from our NICU, PICU, in our nursery. That is not just usually a one patient in that area, it's multiple patients. So knowing that there are multiple patients with naive, immature immune systems in one specific area, so knowing how to handle that. There's frequent contact of these individuals with their parents, their grandparents, their siblings that might be vaccinated, not vaccinated. And then, of course, which you might not think of this right away, but poor self hygiene. Since they are babies, they're toddlers, they're little kid, their awareness of cleaning their hands, keeping their hands out of their face, their nose, their mouth, their in their diapers, it's really challenging of being aware that, they are high risk individuals that likely to transmit other pathogens. The next area is looking at procedure and care risk. As I've mentioned before, with the device utilization, it's more likely that they will have invasive procedure, especially those individuals that are NICU or PICU. So the very sick babies and children, they're likely to have surgeries. So that means more lines and drains and tubes. They will require respiratory therapy. So nebulizer section or CPAP, which often generate aerosols. So individuals in those areas will need a N95 or a PAPR because they are getting exposed to aerosolizing generating procedures along with antibiotic exposure. So based on your invasive pathogen in surgery, you'll always be given a prophylactic antibiotic before surgery, any type of invasive procedure. Because those individuals are naive, their gut microbiome, so the bacteria in their stomach, and not their stomach, but their intestinal tract that is protective to them is very underdeveloped. So it's not very diverse and robust. So even with one exposure to antibiotics, it will greatly change their microbiome in their GI tract, therefore putting them at increased risk of developing C. diff. And based on their age, you will see vaccination gaps in either under-vaccinated or unvaccinated individuals that increase the risk of outbreak. And this is just some data that I pulled from an article looking at the U.S. kindergarten vaccination rates in the United States. You can see that we are in a downward trend on the left-hand side of Tdap and MMR over the last 6 years, but we are not seeing any change to medical exemptions. You can see on the other chart on the right-hand side, there's not really a change in medical exemption, but non-medical or any exemptions of why individuals aren't getting vaccinations have drastically increased, and you can see that on the right-hand side. Even though that we are starting to see vaccination decrease, the American Academy of Pediatrics still supports their 2025 vaccination schedule. And this is just kind of one of the charts that really talks about hepatitis, RSV, diphtheria, along with our influenza and our MMR as well. So making sure that we know when to get vaccinated and be mindful of our pediatric patients of that inherent based on the age of them, they might not be vaccinated because they're not eligible yet. And then here's just a continuation of the chart too. Another thing of looking at is environmental and facility risks. Again, shared spaces make it always hard when we are working with infection prevention and control, especially with kids that they put everything in their mouth, they touch everything with their hands. So knowing what spaces that they are in and then making sure that we have designed our space accordingly so that we know what to do in case someone becomes infectious, they need isolation. Do they have something that's airborne? Is it just contact? And how are we going to separate them? Along with the types of HVAC systems and facility controls that we need to successfully do this. So what room or what location can we put these individuals, especially when there is a wide range of airborne and respiratory pathogens that have high transmissibility between patient to patient. When we're going into the kind of cohorting or communal areas and shared spaces, a big challenge, just like we saw in the behavioral health patient populations, environmental cleaning challenges, especially for our toys. Kids, depending on if this is a waiting room, if this is an exam room, anything that can be touched, they will touch it. So making sure that you have wipeable material, anything that is soft touch or a plushie or something, I would highly recommend removing. I know kids love stuffed animals, but the infection risk is really, really high. So making sure that any type of play toy, book, anything that you have in these pediatric areas, it is wipeable. It is not porous, which are areas that different pathogens, particulates can get in and potentially create a biofilm and become a reservoir for transmission based on that kid's toy. So making sure that we have wipeable areas, wipeable toys and devices within those areas, and that we're using the right and proper disinfection and cleaning agent. We're having the proper wet time so that the item stays wet, so that the disinfection can penetrate the pathogen of interest on it and successfully destroy it. And anytime you can have single use or patient specific items is also great compared to shared equipment. But if you do have shared equipment, making sure that you're always cleaning, disinfecting before you use and after you use. Another thing to consider is your family and visitor restrictions within this area. So not only are you having to worry about the immune and symptomology of the patient, but also their family members, of making sure that that is documented somewhere, especially when we have multiple family members coming in with a patient. When we have an outbreak situation, it's easy to pull the patient record of who was in that specific area over that time. But sometimes with our visitors, we don't have that properly documented. We might have that mom came in with patient, but we didn't have that aunt or uncle or friend, family friend came in there too. So we need to have a good surveillance system of documentation of who is with the patient at all time. Also operationally, when there is an outbreak or if it's there's high prevalence of a certain pathogen within the area, maybe then decreasing visitation risk just to one individual. It has to be a family member that lives in the same home to reduce that transmission risk and outbreak spread of that area. And then also making sure that you have education for the family. So making sure that you're educating the patient, and obviously when you provide education to a baby, that's not going to be effective, but really talking with the family that they know what they need to do to stay safe, especially if they're coming into a healthcare area, they might have to do things differently than at home, and explaining that because of the risk is different in this area, you will have to do additional things, along with having policies and procedures that support infection prevention and control standards, not only for the patients, but for family and visitors as well. And as I mentioned of before, and kind of what I'm echoing, is also being aware of what's going on in this specific community around you. So knowing when there is a high incidence or increased incidence of a specific pathogen. As I mentioned before, we're in respiratory season. So knowing what's going on in your respiratory numbers, going on in your community, that can influence what you're doing in your IPC protocol and procedures, and kind of do a data-driven approach of, maybe you're not masking at this time, maybe you have a threshold or that the pathogen has to spread at this rate, or this many new admissions, or we need to see XYZ on this specific pathogen before the next level. Being aware of emerging diseases. We've seen in Texas, we have resurgence of measles. So being aware that these vaccine preventable diseases due to low vaccine adherence might come and be more frequent within our areas, and then also social and economic issues. So overhouse crowding, limited access to vaccines, and loss or poor healthcare follow-up. Another, as I just mentioned before, the vaccine preventable disease, making sure that we're aware and you're talking and always educating your family members and patients when they come in about it, along with other considerations, as I already mentioned before, the risk of C. diff increases with any type of antibiotic given to the pediatric patients, especially that their gut microbiome is naive. It has only a little bit of bacteria in it. Compared to us adults, we have more food that we can introduce to ourselves that has good bacteria for protection. babies and pediatric populations don't have that. So making sure that we are using antibiotics appropriately and that we are not just jumping to antibiotic usage for this individuals, along with knowing again what's going on for respiratory season, COVID and TB in these areas. And lastly, as I talked about, antibiotic stewardship is really, really critical for these individuals because their gut microbiome and their immune system is so naive. It's really, really important that antibiotics are not necessarily your first go-to. They should be used with discretion so that you don't increase the risk of C. diff, along with other issues, along with antimicrobial resistance. And then because you're not quite sure, because they haven't been exposed to a lot of antibiotics, a lot of things that they don't have adverse drug events or create chronic issues because of exposure. Just like in the adult population, you want to make sure that you are only using antibiotics when used. If you have a virus, that you are using antivirals and not antibiotics, and you're following your anti-myogram and you're working with pharmacy to making sure that you have good algorithm of what you are prescribing based on the certain pathogens within your community. And then just to wrap up this area before we go into the next one, children are more susceptible to infections. There's more significant risks for HAIs, preventable diseases, due to not being able to be vaccinated or have a naive immune system, and antibiotic resistance is a growing issue. The key to prevention is early isolation, infection prevention, and adherence, and epidemiology awareness. So what's going on in your community throughout the state. And the last area is outpatient settings. So our outpatient settings are very diverse areas. They're more of our stable patients, but you will see a wider range of symptomology. These can be same-day procedures, outpatient clinics, urgent cares, freestanding EDs. So you can see dialysis, dental, surgical procedures, or oncology infusion. So you have a huge range of things that can go on in these outpatient settings. Writing your infection prevention plan is really specifically tailored to what type of outpatient setting are you and what are you seeing. So making sure that you are doing your risk assessment, your gap assessment of what could go wrong, who do you see. Another challenging in the outpatient setting is sometimes they don't have a dedicated infection prevention professional. So making sure that that individual, they either don't have an IP or that IP is in charge of 5, 10, 15 different outpatient areas. So making sure that you're leveraging IPC champions, so infection prevention and control champions at each location if an IP cannot be there, to help really drive infection prevention and control standards. And the minimum, making sure that you have OC health and education for staff and competencies are really essential, especially if an IP cannot be there, along with making sure that we have our respiratory fit for our OSHA compliance, along with our bloodborne pathogen exposure plan, and then really driving in the importance of hand hygienes and your policy for transmission-based precautions, along with device safety, environmental cleaning, and reprocessing. Occupational risk, we are just like what we talked about in behavioral health and pediatric immunizations are required. Respiratory, our exposure plan. So our respiratory and bloodborne exposure plans are an OSHA requirement, along with emergency preparedness policies and policies, procedures, and drills, making sure that we know what to do in case if a patient comes into this area with a highly transmissible infection such as TB, or COVID, that we know what the exposure is, we know where they were, and kind of practice this so you are aware, because this is very an atypical situation, that you know who's involved, what should be done, where the policy is, what room to put isolation in, and then really ensure workplace safety. The big thing in these areas is making sure that you are cleaning and disinfecting appropriately. So using your EPA registered disinfectant and making sure that you have the following contact time, knowing your bleach-based, alcohol-based, sanitizers, and knowing how long they need to be set. Also going back into your HVAC considerations, along with just your facility drive designs of knowing where hand washing sinks are, if you need your splash zones, where those are, how those designated separation of clean and dirty areas, if you have any medication in these areas, where is that, and that specific designation of a medication prepared areas, and then looking at your workflow. So specifically looking at your waiting rooms, how that's set up. Is there a way to separate sick versus well patients? Can you space out chairs? What can you do to decrease the transmission risk in your waiting room based on your space, what's available to you? If you need to isolate a patient, what room are you putting them in? Do you know if if that room allows for different change? Can you change the pressure from neutral to negative? And if not, at least just being able to close the door and there's one patient in a room is the next best thing to do. And then with our devices that we use in these space, knowing what classification that they are in, if they are a non-critical item, a semi-critical item, or a critical item, which requires critical items require sterilization. So that's a device that comes into a sterile area of the body. So any of our suture kits, any scissors, what we're doing with those devices versus our semi-critical devices, which comes into contact with our mucosal membranes, so any of our scopes, and they will need high-level disinfection, or a non-critical items which require disinfection or cleaning, and those are the items that come into contact with our intact skin. So making sure you know what equipment's in your space, and then referring back to the manual instructions for use, or the MIFUs, and then knowing how to maintain them. So how do they need to be cleaned, high-level disinfected, or sterilized? Where are you going to store them for high-level disinfection and sterilization? Again, there are requirements for negative pressure, temperature, and humidity, or positive pressure based on the device. So there's that pressure, temperature, and humidity component of that. So making sure your area is set up. And then knowing who's responsible and the duration. So if you need to reprocess them, so if that piece of device is not used in X amount of days, is there a way to capture that? Who is auditing that? Do we know when to send it out? What's our send out time? If we then, are using this piece of the device only on once a month or once every 6 months, if we need to send it out to be reprocessed, how long does that take of getting that piece of device back? Can you get a loaner device or a piece of equipment from a different area? Those are all things to be considered in those outpatient areas of what equipment is there. And then going into surveillance, just like in the pediatric and behavioral health, it must be targeted. So what are you seeing in your area? Are you seeing any surgical sites for surgical site and centers? Are you a dialysis center? So you're having central lines, so you need CLABSI monitoring for HAIs. Are you prescribing antibiotics? So you definitely need to be looking for C. diff. Along with anything else, making sure that you have a system in place for high-level disinfection and sterilization, and that you are auditing that. So earlier this year in the 300 series, we talked about sterilization and high-level disinfection. If you're not quite sure what that looks like, I encourage you to go back to those 300 Tuffy series lectures to look at the in detail process that involves for high-level disinfection and sterilization. And then doing surveillance about notifiable conditions. So if you are testing cultures, who's responsible for letting public health know that this pathogen was found? Is it your clinic, or is it the lab that has the positive test result? And then lastly, looking at outbreaks, making sure that you are aware of things that are going on. And most often in the outpatient space, they're tied to unsafe injection practices. So poor needle injection, cleaning, or reprocessing failures. So making sure that we have really tight, safe processes. Our staff know how to handle needles, how to have safe injection. We are not overstuffing our needle boxes. We know who's cleaning, what piece of equipment, how it needs to be cleaned or disinfected, and then reprocessing and making sure that we know when, where, and how often we need to send out. And then making sure that we follow up with public health anytime that we have a breakdown in process that leads to an outbreak investigation. And then we're following up with a root cause analysis and making sure that we are addressing these actions and identifying where we went wrong and areas of improvement so that they don't happen again. Some common challenges, as we've talked to, is hand hygiene and environmental cleaning, injection and medication safety, as I mentioned before, making sure that we are not overstuffing our needle boxes, that we have clean areas for medication preparation, and that those zones are designated and staff know how to handle these equipment so that we're not accidentally introducing any sort of pathogen in them, along with our monitoring and surveillance on device associated procedures and relative risks. Another big issue is immunization. So making sure that we are aware of not only what our patient's vaccination is, but our healthcare workers, along with our compliance. We know how to wear our mask. We are properly N95 fitted, and be mindful that every N95 brand fits differently. So if you are a certain size or fit in one manufacturing brand, if your facility gets in a different type of N95, you will need to be refit for that, because they do not fit the same. And then making sure that staff know this and not think it's just a one size fits all type of thing, and that they are aware of what their size is, how to wear it, and if they need to be refit, along with looking at surveillance. Another big challenge in our outpatient setting is sometimes we don't have benchmarks compared to the inpatient or acute care side. So knowing what your utilization is for certain devices, certain procedures, that then you can monitor and kind of develop an internal benchmark of where you want to be. And then making sure that we have really good processes in reporting communicable diseases. Again, as I mentioned, making sure that we have ownership and accountability. If we have a positive test result, is the laboratory reporting that, or is the clinic reporting that? And then lastly is having gaps in training and education, especially if there's not an infection preventionist on site. So making sure that we leverage those IPC champions to really help drive IPC challenges. So next we're doing our, they're very diverse. They create, this creates a unique infection risk, and these programs must be adapted based on your specific organization. So now we're going to quickly go through the knowledge check. So I invite all of you to scan the QR code before we open it up for questions. I know we're getting close to time. I'll have everyone scan the knowledge check. So the first question is, what factor increases the risks of most in behavioral health populations? Is it A, individual patient isolation, B, restrict visitor, C, communal living, or D, limited use of group therapy? Yes, the answer is C. Question 2, why is alcohol-based hand rubs sometimes restricted? Is it A, it's less effective, B, it may damage communal surfaces, C, it's unavailable, D, it poses a self-harm risk to patients? Great, it's D. Question 3, what is a key strategy for outbreak prevention in behavioral health facilities? Is it A, B, C, or D? Great. Yep, the answer is B. Question 4, which factor most contributes to increased risk of infections in pediatric populations compared to adults? Is it A, B, C, or D? Great, that's B. Question 5, which of the following is a procedure-related risk factor for pediatric infections? Is it A, B, C, D? Great. Question 6, why is antibiotic stewardship especially important in pediatric setting? Is it A, B, C, D? Yep, it's B. Question 7, which of the following is a common infection prevention challenge in outpatient clinics? Is it A, B, C, or D? Yep, it's B. Question 8, according to the Spalding classification, this is a semi-critical item. What does it require? Is it A, B, C, or D? Excellent, it's B. Question 9, immediate notification of public health authorities is required in outpatient settings. When? A, B, C, or D? Great. C, outbreaks are identified. And the last question, why is IPC especially critical for these specific areas? Is it A, B, C, or D? Great, it's B. So here are the answers. I know we went through that really quickly. So just kind of to wrap up, these areas are address specific unique vulnerabilities. Making sure that we have surveillance and outbreak response and identification is really key, especially with early detection. Promoting antibiotic stewardship is always a way to reduce resistance. And then enhancing education, engagement of staff, patients, and families to reinsure IPC practices is a key way for IPC prevention strategies and promote a culture of safety across all healthcare settings. So great. So I will ask you all to connect with us. And so here's our contact information. You can email us at IPC@TEFI. And here's the QR code if you want to see other TEFI groups. So just an announcement, this is our last lecture of the 300 series. So thank you all for attending. I ask that everyone please complete the post-module evaluation, the QR codes here. You've also seen an email about the series evaluation for the whole year. If you've already completed this series evaluation, you don't need to complete it again, but here's the QR code if you need to do that, and encourage you to do that along with our previous TEFI publications as well. And one last announcement before I open it up for questions is that IPC office hours are next week on November 13th from 2 to 3 Central. Please email the IPC for the invite if you have not received it. This is an area for networking, connecting, and kind of sharing IPC issues. And then here is the slide for the continuing education instructions that you'll need to complete. So now I would like to open it up for any questions. Are there any questions in the chat?
So somebody asked if there are measures to address staffing shortages.
If there's measures to identify staffing shortages?
To address them.
That is up to your organization. I know in all areas of healthcare, we are seeing staffing shortages from our physicians, from our nurses, our MAs. So it depends on what specific state you're in and what specific organization, but I'm not aware of a specific metric. It's all dependent on your state and your organization.
And the question we have in Q&A, I guess we have two more. How can business owners share or collaborate on future endeavors? Is there a way of, I guess that would be probably your town halls.
Yeah, definitely sharing this information through town halls, especially what's going on in the community. If you're looking at your communal spread and epidemiology factors of doing town halls, sending out emails, doing huddles with your groups or within your departments of what's going on in the community. So then there is increased knowledge about screening. Some great things that I've shared in previous lectures have been the HONs, which are the health alerts that go out, what's kind of circulating on the community, and then also working with your local public health, reaching out to them to see if they have any alerts that are going on, any notice of what's going on in their specific community. It's also good to know what's happening in the state or two over so that you can kind of prepare if you need to start asking additional screening questions. Excellent question.
Okay, and how can outpatient oncology center set up CLABSI?
Great. So your outpatient oncology areas, because we have device utilization, especially if you're using central lines or if our patients have ports, making sure you're following up with that patient of what's going on with that, especially that when they come in for their infusions, that we know how we are monitoring them. Depending on what type of network you're in, it's easy when the patient stays in within the system. So saying if the patient goes into an outpatient oncology and Methodist, and then if something happens and they get admitted on the inpatient side of Methodist, of then, asking the IP to follow up with you. Another thing to do is when you're screening your patients coming them in, ask them about their port or their line. Have you noticed any redness? Have you noticed any draining? Have you manipulated it? Have you been admitted to a healthcare facility lately? Was there an issue with your line and drain? Any of those types of questions. So just even asking your patient about it, it can be a great way. Or if you're seeing any type of other cultures, if you are within the same network, as I mentioned, that if you can dig down in their other visits when they're coming into your facility, if you can see that they've been admitted on the inpatient side, looking to see if any cultures have been ran, and then based on that, kind of doing an investigation. And I'm happy to talk offline about that too, if you have a specific question. Sorry, Dana, what did you say?
No, I was just going to say, somebody posted in the chat that a health alert from the state health department just came out today for an increase in pertussis.
Yes. So making sure that you are checking your local and state health alerts, making sure that you're following up with public health, that's a great way to know what's going on, especially in these very specific populations and just in any healthcare setting, so that you can be aware of when patients are coming in on the outpatient clinic side or on the inpatient side. If you need to ask additional screening questions, you know what's going on in the community, so you can tie that in and kind of be more preventive and identify them, isolate them, and get cultures or assays done on the beginning of the stay instead of 5 days after they've been in clinic or 4 days they've been in inpatient location.
That's all I have for the questions.
Awesome. Well, thank you everyone for participating. I know we went through the learning activity kind of quickly. Please reach out if you have any questions. As I said, today's lecture is recorded within 1 to 2 weeks. You'll receive a link to the recording along with the slide deck. Please reach out if you have any questions. I encourage everyone to come to the IPC office hours. And lastly, please complete the post-survey evaluation and the series evaluation. And I thank you all for attending today's lecture, or if you've attended any other lecture this year. And I look forward to seeing you in the new year. Thank you.